Natale. I am going to present to you my Capstone project, which is titled Behavioral Emergent Response Team. A little bit about me. I am a board-certified psychiatric nurse. I have been for about 6 years. I worked on an acute care inpatient psych unit. Hence, why I'm presenting this project is I used to get a lot of calls from other services wanting our expertise on how to control behaviors in other areas of the hospital. So I would get a call from MedSurg saying, please could you tell us how to help this patient maybe stop yelling or escalating. Because we were the trained specialty, they would tend to call us a lot. So we realized that the need needed to be in the hospital more because of the more prevalence of violence coming into the hospital. So today, our objectives are going to be to identify the behavioral emergent response team, to define the key terms, to describe the themes discovered in the review of literature, and to list the recommendations. Key terms. A BERT is a behavioral emergency response team. It is a consultative resource that may be used when psychiatric behaviors present in non-psychiatric settings. The responders would be a psych nurse, it would be security, the nursing supervisor, and a mental health therapy aide. Behavioral emergency, it occurs when the behavior of an individual is out of control and the individual becomes a danger to self or others. Nursing, it is the promotion, protection, and optimization of abilities and health. It is the prevention of injuries and illness and the alleviation of suffering from people by diagnosing and treating. And it is the advocacy in the care of families, individuals, populations, and communities. And teamwork. It is defined as function effectively within nursing and interprofessional teams, fostering open communication, mutual respect, and shared decision-making to achieve quality patient care. So, overview of my topic. Behavioral health is a topic with growing societal importance. It makes national news when something catastrophic happens. An example of this, national news, last month, there was the airplane that went down in the French Alps. It was a pilot who decided prior to or during that flight that he was going to suicide. He took down 150 passengers. That was in the community. When we take it to a hospital setting, it is just as catastrophic. I will show you a video that made national news, and it was headlines in a hospital in Missouri. Forming a rapid response team by de-escalating potential violent and volatile situations proactively in non-psychiatric units and hospitals allows for faster and earlier management and treatment for those behavioral issues. Hospitals should consider coming up with a behavioral emergent response team to assist the medical staff in the hospitals in de-escalating patients who are potentially violent with their behaviors. A little background information. 1 in 4 American adults suffers from mental illness in a given year, with 1 in 17 suffering from a serious mental illness. To differentiate between the two, mental illness could be anything from depression, anxiety, and serious mental illness, meaning that it's something such as schizophrenia or bipolar that could affect their activities of daily living. Occupational Safety and Health Administration says that workplace violence prevention guidelines reveal healthcare workers face a significant risk of job-related violence. I was at a conference a week and a half ago, and one of the statistics that was presented at that conference was, it was a study done by Duncan in 2000. It was over 8,700 staff from 210 hospitals were interviewed, and it was found that 46% of those staff interviewed stated that one or more in the past 5 shifts had experienced a violent act. So that's the increase of which violence is happening in our hospitals. Nurses in non-psychiatric settings are expected to provide care to patients with mental health and behavioral issues. We can't pick our population. We don't get to pick and choose our patients. They're on the med-surg units, they're in the hospital. Nurses everywhere have to care for these types of patients. And by lacking BERT in a hospital setting, patients with psychiatric behaviors pose danger to themselves and other patients and to the hospital staff. So this is a statistic that went with my previous slide. It's any mental illness among the adult U.S. population. It is 18.6% of the adult American population that is diagnosed with any mental illness. And the prevalence of serious mental illness in the adult population is 4.1% of the American adult population. This is a clip just to show you what it would look like.
Civic, listen to this. It's a brand new 2015 Mazda 3 with a new body design and Skyactiv technology. For once,
and they refer to them as deficiencies. I have the documents here to show you.
Oh, go.
If you excuse me, is the job.
69 a month with only $900 down. Bottom line.
We begin tonight with the release of some disturbing video showing an attack on nurses at St. John's Hospital.
It is hard to watch, but it shows just how dangerous the job can be amid concerns violence like this is on the rise. Carolyn's Trisha Volpe is here with our top story tonight. Trisha?
Well, Julie and Randy, there is no other way to describe this video. It is security video from inside St. John's Hospital, and it is horrific. A man with a pipe he took from his hospital bed attacking nurses. By the end of it, 4 nurses are injured, and police find the man several blocks away. He dies after being handcuffed. No one knows exactly what led to this, but police say Charles Logan had been hospitalized with episodes of confusion. Though hard to watch, the video highlights an issue hospital workers deal with on a daily basis. National numbers show violent attacks on nurses and doctors going up, and hospitals becoming more and more fortified. We have been looking into this issue in Minnesota, where the Department of Health recently formed a statewide task force on how to prevent and respond to violence in the healthcare setting.
So we've heard stories of primarily nurses, because they're the largest portion of the healthcare delivery workforce, who have been hit or spit on or punched or been subjected to some sort of verbal or emotional abuse. And that makes the workplace a very stressful place for them to be.
So with that video, I don't know if the hospital in Missouri, St. John's, has a behavioral emergent response team. But hypothetically, if they had, and if they had seen this patient becoming aggressive, becoming agitated, at the first signs of his escalating behavior, they could have called a BERT. The team of psychiatry could have reached this patient and could have de-escalated the situation. They could have medicated him, they could have talked with him, they could have seen exactly what his needs were to possibly prevent that from happening. Usually the BERT team is activated so that way we can de-escalate the situation by allowing the patient to voice what their needs are, to taking that situation from 0 to 100 in 2.2 seconds. So it's really to stop that, so that way you don't get somebody who is acting out and hitting people with pipes or injuring staff or other patients. So my PICO question, my population is the adult inpatient hospital population. My intervention is, does having a behavioral emergent response team compared to not having one? My outcome would be to decrease the risk of injuries to patient and or staff. So my PICO question would be just as that. Among the adult inpatient hospital patient, does having a behavioral emergent response team compared to not having one decrease the risks of injuries to patient and or staff? The theoretical model that I chose to use is Lewin's change theory. He has 3 stages. It is unfreeze, change, and refreeze. The unfreeze stage would be ensures employees ready for change. The change stage would be to execute the intended change, and the refreeze would be to ensure that the change becomes permanent. A little analogy that I like to use just to kind of show you the way that this theory works is if you had an ice cube, a square ice cube that comes out of the freezer, and you're going to unfreeze it. It's going to turn to a vial of water. But if we put it in a cup, it's going to turn to a little bit of water in that cup. Well, we want to change the shape of that ice cube, so we put it into a cone. And so we've changed it. We've now put the water into a cone shape, and we refreeze it. So now it's a cone-shaped ice cube. Well, it's the same idea. You're taking something, and you're unfreezing it, changing it, and refreezing it. Using it from my theory, the frozen right now is that we don't have BERT in the hospital setup that I currently work at. So I want to unfreeze it. I want the hospital to be introduced to the BERT team. I want to empower the nurses to know that this resource is going to be available to them. I want to change it. I want staff to embrace it. I want them to know what the BERT team is, who it consists of, how it's going to help the organization, how it's going to keep nurses, staff, and patients safe. And then we want to refreeze it. We want it to become part of the hospital setup. We want to make it policy. We want nurses to utilize it whenever they feel the need to utilize a BERT. So my review of literature, I started off with the most comprehensive CINAHL, and then I went to use Medline, PubMed, and NCBI. I initially started off by over 3,000 research articles using terms with behavioral emergent response team, behavioral emergencies. I ended up with 35 articles from CINAHL and 5 from psych articles. In the data extraction, the factors that I considered were the study design, the performing year, publication year, the characteristic of population, the geographical setting, and the variance risk estimates. The search strategy was electronic databases, conference abstracts, and the internet. I used 6 articles relating them to the behavioral emergent response team. I found it very interesting that I was trying to say that these are patients that are not on a psychiatric unit, and that I want to reduce the risks of injury to staff or patients. 3 of the articles said that these are hospital patients that are in non-psychiatric units, and that they reduce the risk of injury to both staff and patient. So it was pretty strong evidence as far as these were 6, and the area of study hasn't been studied a lot. It really needs to further, but the 6 that I was able to get showed that if we were to do this, we could possibly raise so we don't get hurt in our hospital setting and the patients don't get hurt. So in summary, the strengths of the articles were the BERT offers a valuable resource for both safety, for both staff and patients. BERT has raised employee satisfaction surveys. The 2 hospitals that I know that are using BERT, there's one, it's 5 hospitals in St. Louis, they're called St. Mary's. They are using it and the VA administration uses it. Their employee satisfaction rates have gone up. The employees are stating that they feel safer. They're staying, so their retention rates are better. It increases collaboration between psychiatry and other medical areas. I can personally say, I've worked in psych for 6 years. I sometimes get that feeling of when people say, what do you do? And I say, I'm a psych nurse, and I go, oh, Okay, you're psyched. So you're kind of known as the redheaded stepchild of the hospital. But in this situation, you're kind of embraced and you're welcomed, because this is a scenario where their behavior's out of control and they're calling on you to come down and say, help us take control of this situation, help us be able to manage this patient. So it really kind of brings the teams together. And most studies commented that the nurses, knowing that their assistance requested in management of emergent behavior situations, they were being addressed. The limitations of the articles were that the biggest challenge of BERT is that to ensure that the behavioral health staff was readily available when they were requested upon. And that the role of the respondent, it requires flexibility, and the team has to be able to get to the emergency quickly. So that was one of the challenges. Clinical relevance. BERT is relevant and can be applied in hospitals to avert potential harm, violence, and keep staff and patients safe. An example of a clinical application of BERT is in a med-pulm unit, since this is an area that comorbidity of psychiatry issues exist. Other relevant medical units that BERT can be applied would be critical care, med-surg, and the emergency department. Our Code of Ethics Provision 1 states that nurses practice with compassion and respect and inherent dignity, worth and uniqueness of every individual, unrestricted by considerations of social or economic status, personal attributes, or the nature of health problems. This is why nursing is taking this on, because we can't pick and choose our patients. But what we can do is offer a resource, so that way we can safely take care of our patients. Using Lobiano Wooden-Haber's level of evidence, the recommendations that I have come up with is BERT teams should be structured in a hierarchy with better communication lines clearly outlined. The communications from the medical unit to the behavioral health service leader, the BERT leader, and to the team members. The BERT team should readily be available when called upon in cases of the emergencies. The team members should be qualified, have proper education, and understand their roles to avoid lack of confidence among the team. And the BERT team should always have an all-around team working in all shifts, both night and day, to ensure that the availability is there when needed. So in conclusion, BERT is a resource for meeting the growing behavioral emergency management and increasing rate as reported by the increase in patient violence.